Okay, so welcome to Behavioral Health. And I always have to share that we're a part of Public Health Institute, and we do share our materials under Creative Commons, no conflicts of interest. And make sure one important thing to do is put in the chat box, if you could please make sure there's a blue little box in the bottom. It says panelists or everyone. Make sure if you put a question in the chat that it's addressed to everyone, because then it only comes to us and then nobody knows what you're asking. So please make sure that you do that right now. And then I always like to, before I get started, talk about California Bridge. You know what our goal is, you guys. You can answer this one. 24/7 access to high quality treatment of substance use disorders. Our goal is to complete all of the hospitals in 2025. And right now we're at 275. So well on our way. You guys know what the bridge model is for our new folks that are just joining us. It's very simple. Low barrier treatment in the emergency room. Our physicians, our nurse practitioners, our PAs are giving low barrier treatment. That means a patient can come in and say, I'm in withdrawal. And guess what? There's not a bunch of tests. There's like, okay, we can treat you. We can give you buprenorphine, right? And then the last two are what you guys do every day in your role as navigator, connecting to care and community. And that's including with that warm handoff and making resources. And we got another resource today to share. And actually the last pillar or last focus is harm reduction, reducing stigma. And that goes with mental health as well. There's so much stigma, not only in substance use, but with mental health. A lot of people just, regardless of socioeconomic class, race, gender, it touches everybody's lives. So thank you for what you do. You guys are doing this and living our model every day, and we thank you and appreciate you. This was our, I jumped ahead because I was so excited about sustainability, right? So this is for our next focus series. These are our objectives today. We have a bunch, but you're going to know everything. You're going to know a lot more after you leave. Let's just say that. This is our social work panel. And I am going to shut off my screen. Aiden is our comms people, so we can talk to David and Yvonne. David, do you want to introduce yourself?
I'd love to. So my name is David Riker. I'm the lead medical social worker for emergency medicine and per diem staff at Long Beach Memorial and Miller Children's Hospitals at Long Beach. I am also one of our hospital's LPS psychiatric clinicians. So I get to wear tons of little hats all at once. So I'm really excited about talking about the overlap of those roles.
Okay, thank you, David. Yvonne, can you introduce yourself?
All right, thank you. I am Yvonne Nebo. I am a social worker at Northridge Hospital. I am embedded into pain management department and transitional care in the hospital at Northridge Hospital, but I am also the substance use navigator in the emergency room at Northridge Hospital. Nice seeing you all.
Thank you. Well, we're happy to have you here. And I want you guys to start off by letting us know, David, I'll start with you first. Give us one strategy for working with behavioral health dual diagnosis patients. What's one thing you can tell our navigators? A helpful strategy tip? What's one thing that comes to your mind?
So I think one of the most important things, especially in the environments in which we work, like hospitals, emergency departments, community outreach, working with people who have lots of overlapping psychosocial issues usually, is treating them like a human. And I know that sounds kind of cryptic and not intuitive or very intuitive. But when we get into the helping profession, especially within a hospital where the culture is kind of dehumanizing, it is very important to treat people as a human and understand they're an intersection of many different facets. How do we do that? Using non-stigmatizing language, just like Sherry just told us, building that rapport and that trust, because we're coming in a very short period of time. They need to be able to tell us some of the most sensitive parts of their life, and they need to trust us in a very short period of time. So coming in and having that warmth and having that, I'm a person, you're a person, man, this place is crazy, there's a lot going on. How are you doing with all of this? And rather than going, and how many grams of heroin do you use per week? So try and make the interaction and the interventions more of a conversation.
I love that, David. In fact, I got a call earlier. That's just so funny. The same wavelength of, the question was, the case manager wanted to send the navigator in there because the patient was not telling the truth about their drug use. And so, you bring up some great tips and strategies. Thank you. So Yvonne, I'm going to give you an opportunity to share one strategy, one tip that you really want to get across to our navigators to help them.
I think for me is to broaden our lens a little bit more. Every day is I challenge myself to expand my lens because I wear frames, I wear glasses, but what I do every day is to make sure that my lenses are wider every single day and being comfortable with that. Because when we widen our lens, then we have a broader picture, and there's so much room as to what we can do every day for ourselves and for our client and the patient.
Oh, hold on, Yvonne, you cut off.
An accident, so my
That's
apologies.
okay. No worries.
Is to widen your lens every day and being very comfortable with that, and also showing people enough grace not to understand how wide you're willing to expand your lens, because you're going to have people that may not understand your choices of widening your lens. But if we do show them, you give them the grace, right, then we can be able to maybe widen their lens no matter how small they're willing to go to, and also being very okay with that piece as well.
That you say so, being comfortable, both of you. I think that's the theme, is being comfortable, having that openness, right? I love this because I know I'll divulge, when I was first nurse, I did not like going to the psych unit. Okay, I'm just gonna throw that out there, you guys. Okay, this was 30 years ago. Okay, I'm divulging way too much here. But I was scared. I was very scared. I've heard all the stories about psych patients hitting people and that comes to mind. So I love the fact that you guys are both widening your lens and just being open to what's going on and not having that fear and those prejudice and that stigma around it, because I think that's a really big challenge for some people. So I appreciate that. So if you guys have questions, please put them in the chat, and I'm going to ask Latoya if I can't see the chat. I'm going to do the slide presentation. So if there's something, Latoya, can you please let me know and we can address that question. But we've had some questions already sent in. So I'm going to ask Yvonne, how could we better collaborate as a team to make sure patient needs are met prior to discharge? How that's always really hard, because sometimes our navigators got I'm not going to use the word dump, but I am going to use the word dump, right? Okay, you guys can relate to this. I know sometimes consult and it's like, why was I consulted? Right? Okay, tell us about that, Yvonne.
I do love that dump, because I hear that also very quite often, and I go, you know what, it is okay. But then again, how much of the dumping are we also willing to accept, right? Because we have to model the behavior we want to see, even with our patients. So, but for me, collaboration is a practice for me, and collaboration has been something that I've for years now decided that I'm going to take on to make that a model and a practice for me. Because without collaboration, there's really no way to move forward towards all of this. Because if we're looking at co-occurring, right, disorder in addiction, the opposite of addiction is connection, right? If the opposite of addiction is to connect people, then we have to be comfortable in embedding connection and collaboration into our work. So collaboration and connection is really important for me. My lens are not just you're here for substance use. If you're on the street I understand that asking to go to rehab at that time is not really feasible, but how can I get you connected into a housing, whether it's interim housing that could lead to permanent supportive housing, right? And then we can talk about cut down on use down the line. So collaboration for me is very important, that I try to look into housing opportunities. I have patients that come in with dogs, pets. Well, if I go to treatment, what happens to my dog? Well, can I find you a pet clinic where your pet, or pet shelter where your pet can go to? I don't have insurance. There's no medical. I work with Elevate. I work with admission people. Sometimes they're annoyed, but I'm like, I know that you're busy. I know this is something else you have to do, but I'll go in there with you. It take a minute, right? Let's get you emergency medical. So for me, the goal for most staff medical team, their lens is different from what we do. So we have to support them in understanding our capacity as well, right? So connection and collaboration is very important in terms of, appointments and housing needs and the pets and where can you wash your clothes, right? To make sure you come back. And then accessibility. If you leave tomorrow, here's my number. Give me a call from 7 to what time. I'm here to make sure that you get connected to what you need in the community. And literally they do call. And one was excited last week. You answered. I answered. I gave you my number. And he's like, you know what? Because you answered, this is what I need. I said, okay, let's get it done. If you come back at so and so time today, we'll get it done. And he showed up. And this is someone that we haven't been able to get in touch with in the ED for 5-6 months. Mm-hmm. So being able to connect with folks and being comfortable connecting and collaborating with other people that may not have the same idea and worldview as us. Right? That's where, again, that grace comes in. We have to give them the grace enough so we can connect with them and collaborate with them to get our patients what they need.
I love that, Yvonne, when you say you answered the phone. For some, that's the trust, right? You gave me a number. If you don't answer the phone, it's kind of already, well, they don't care. They don't realize you may be with another patient, but yeah, that's really important. I tend to answer the phone and then tell them, hey, can I call you back? Can I get your number? I think that's such a great answer. Thank you, Yvonne. David, I am going to ask you, how can we help the patients we know need mental health stabilization and meds before being able to even participate in an SUD treatment?
Yeah, so that's a really good and pertinent topic for all the patients that we see, given the prevalence of both individual substance use disorders and mental health disorders, much less the co-occurring population, where it gets into that question of, do we treat this? Do we treat this? When in reality, it's very much a chicken and an egg situation, as a lot of people will have one because of the other or as a consequence of the other. So finding longer term planning, finding resources that are able to treat those concurrent issues and having those referrals is going to be fantastic for your patient population. In the short term, you very much do need to address the psychiatric component, particularly for those patients that are in crisis and may need to go to a psychiatric institution. A lot of that work in terms of setting up the planning around the buprenorphine dosing, possibly even the induction, can be done in the emergency department. And then it would just be maintenance from that point forward, or doing the education and preparing them for when you do go back into the community, whatever that looks like. Here's my information. Here are the places that we discussed, because while this is big and scary and very intense right now, it will get better with time and with work, and we will help you walk along that process, whatever that looks like.
I love that, giving them solutions right there in the emergency room that don't take a lot of time, because sometimes I think that's part of why they leave, right? Things just take time. I have a question. I do see this in the chat. Emily wants to know, can the panelists speak to boundaries and advocacy? I find myself working with a high sense of urgency to help patients get connected to care. What is the best practice to avoid burnout? So it's kind of just learning the boundaries of what you can do, right? Yvonne, do you want to take this first?
Yes, I will. Boundaries is often something that's very recently, there's been a lot of research around that, which makes me really happy because I think that boundaries, when explored, makes people uncomfortable at first, right? Because we're so used to, oh, I want to do this, I want to do this, I want to do that. But also understanding our capacity is very important. If I stretch myself way too thin, and then I cannot be what I want to be to my patients. And also to some of the physicians I work with, to my colleagues, and to my kids, and to my family. So boundaries is also something very important. So what I always ask myself sometimes is, when I get to a space where I feel like, oh, I think I'm doing a little bit more, is just pause and say, okay, why is this? Why the need to stretch myself a little bit, right? Being open to recognize why you're doing that extra task that you feel like you don't have the need to do is important, right? Because if you stretch yourself too thin, then you cannot be what you want to people around you. But also sense of urgency is something we see also doing this work in the emergency room, right? But also saying, let's take a minute. And at first, for the staff in the ER, it was kind of interesting. What do you mean take a minute? I said, I understand the urgency. I can see that you're uncomfortable. I can see this looks big for you, but let's take a minute so we can get it right, right? And that moment of pause gives clarity to what is actually happening. And then being able to also go, okay, let's now explore what's happening, what you're sensing, and what we need to do moving forward. So the sense of urgency I see in the emergency room, and I understand that it is called the emergency room for a reason, but that doesn't mean that we have to go through the emergency by ourselves, because we want to have solution for our patients. Right. And that's also the same, my model is that if I come in with a sense of urgency, and my patients, because they can sense the sense of urgency, then that becomes the pattern that they know. So we need to disrupt that thinking of urgency. Let's take a minute so we can have clarity.
I love that. Thank you, Yvonne, because I think it is, in the emergency room, and lots of doctors and nurses that they run on that adrenaline, right? In and out of the room fast, everybody walking fast. Really love that. David, do you have any other words to add to that?
Yeah, it's very much that is just the culture of emergency medicine. It's an emergency. And even if, in our hospital, we try and make a distinction between medical acuity and psychosocial acuity. Is yes, their physical presentation may be one thing, but if someone thinks their addiction issues are bad enough to come to a hospital emergency department or be brought by a family member or a friend or someone who cares about them, that's probably one of the worst days of their life. And we see this consistently day after day. So you can become kind of numbed to that. But it is both holding, it's not really an either or, it's holding. This is a crisis, this is an emergency, this is something that needs to be addressed. But we also want to make sure we do it the right way. And we want to take our time and respect you, treat you like the person that you are with your unique needs, and walk through that process with you. To avoid burnout, self-care, and having a really good understanding of what's called scope of practice. What are the expectations? What are appropriate for you? Who does what? Because if you feel like you're taking on all these responsibilities for things you don't know how to handle, or dumping, they probably aren't things that you should be handling. And then you need to go to the unit management or your director or whomever and help problem solve these pathways. And then make sure you're taking care of yourself, because as they say, you can't pour from an empty cup. So learn what works for you. And if you've not been to therapy, go to therapy.
I love you guys. This is why I have these two here. Like, I could just talk with them all day long because they have such pearls of wisdom here. We have a hand raised. So who is that with the hand raised, and can they unmute themselves for a question? I can't see anybody. I'm sorry, you guys. I can't see it.
I think it's Donna. Donna
Harris.
Harris.
Yeah, it's Dana Harris. Are you able to unmute Dana?
Hello?
If not, you can always ask your question in the chat.
There you go, Dana. I just heard you. Go ahead, Dana. Do you have a question for our panel?
No, I didn't. That was an accident. I'm sorry.
Oh, okay. Well, you were gonna answer it. Come on. I think
Sorry.
we have another question. So that was before, but I think Dana was going to ask, what are expectations from a son, from a social worker view? What are your expectations? Because a lot of times we hear this from a lot of people that it kind of, they cross, they cross the scope of work. So if each of you can answer that, what would be, as a social worker, you guys are working in a dual role. So I think you guys have better insight for our navigators than maybe somebody who's not a social worker. So David, do you want to start with this one?
Sure. I very much look at it as we are social workers that have a very enhanced skill set, specializing in the treatment and specialization of identifying, treating, and connecting patients with substance use disorders to whatever system is going to be appropriate for them. Because it does dovetail really nicely. I mean, all of these health and human services issues that we as medical social workers deal with are very much aligned with the values of the Bridge program, we're all kind of rowing in that same direction. It's just, again, that expectation of which of the oars are you supposed to be pulling? Because, for us that do both jobs, we're pulling two, both the social work and the substance use navigator role. But having that distinction and understanding, especially if you are solely a substance use navigator and you've got a social worker, a discharge planner, a case manager, a community resources worker, like you might have many people that are helping out with very similar tasks or problems. So making sure you're all aligned on those same pieces. And that's, kind of how my staff uses me at the hospital. Is we're a staff of 55 social workers between our two hospitals. And when they have a pregnant patient who needs to be on buprenorphine or they need maintenance of their buprenorphine and the medical staff is saying, oh no, they're going to be under anesthesia, so X, Y, or Z, going to the inpatient units and helping consult on those cases. The social workers will oftentimes carry their own cases. I'm going as a supplement, focusing on those substance use components that are my expertise.
Oh, I love how you say that. You're supplementing, because a lot of times the social worker is always on the case. So, definitely being the specialist in the MAT process. So I like that. Yvonne, can you say anything about this, please? Something?
So my view is slightly different.
No worries. Every hospital's different. That's why we have different views here.
We are all, whether you're a social worker and you're not a social worker and you're address yourself, I'm a substance use navigator, I'm not a social worker. We are all experts in our own ways, in our own areas of life, right? Same way we tell our patients that they are experts in their lives, right? And the same way we are experts in our lives, and we have the intuition, we have the knowledge. It's just finding the balance to sit on that comfortably. Is that whether you're a social worker or you're not, and you're doing this role, this is one of the only role on the only field that we come because our experiences brought us here. So let's lean into that experience and sit comfortably in that experience and do the jobs that we're here to do, whether you're a social worker or not. That's how I see it. But also I see a question in the chart as a social worker that are not navigators doing this work. It is very tricky and it's challenging because I get that question all the time with ED social workers. I don't understand what you do. I don't know what you do. I don't know how you can break down drugs with patients. I've never done it. I'm not comfortable doing it. It's not comfortable for me. Because I was literally breaking down drug use in the ER last week. Like, okay, you've overdosed twice. You don't want the resources, but you're using more. How many are you using? Okay, so let's put the paper. Let's cut it down. If you use this much, you save this much, and then you save money. You don't have to go buy more, and then you can have money for food. And she's going, "What? I cannot do that." Right? But the thing is, for me, is that the goal is comfortably sitting in this to know that my goal is to save this person's life and not my discomfort.
Very well said. Very well said. I like that. We're all experts.
Educate. So education, and being very comfortable, sitting comfortably in what you feel or know about your own specialty in your area.
Right. And I think that answered Naranifta. I'm probably saying it wrong. Naranifta. Neri. Okay. Thank you, Latoya. I hope we answered that question for you. Is there any other questions you guys have before we kind of go to a case study? Any other questions out there? All right. Yeah, I think they answered our questions. And if you have more questions, please put them in the chat. This isn't the only time. So I'm going to share my screen again. And let's go back. And we're going to look at this case study. So this is really interesting. This is a 35-year-old white male patient, came in because he was having bad thoughts. His friends brought him to the ED. He stopped taking Zoloft, gabapentin, and Abilify last month. His last drink was early this morning, and he admits to drinking a pint of vodka. He does not appear in withdrawal at present time. He's smiling, friendly, and polite, answering all questions. Psych eval is pending, and you are consulted to see him. Where do you begin? There's a lot here, and this is kind of a normal patient, you guys, right? This is somebody that I know I've had in my ED. I know you guys have. So what's the first step that you start with? David, we'll start with you. Where do you go with this patient?
Well, first is introduce myself and then why I'm here. And then usually I start with what brings you to the hospital? Like, what brought you to the hospital today? I talk with the nurse and the doctor, and they let me know a little bit about what's going on. And it sounds like your friends are pretty worried about you. What's going on? And then using that open-ended question to kind of have a jumping off point, because if they answer, oh, nothing, it's just the usual, I just, whatever, like that's, you're gonna have to do a little bit more digging with that versus someone who immediately starts crying and says, I've really been struggling lately. I lost my job. I just don't see any point in going on. Very different answers, and how we would treat them would be different. But I like to put that power back in the position of the patient for them identifying and defining what are we dealing with to start.
I like that. I like just, getting down to their level, making it really easy to talk to you. Yvonne, what are the next steps after that beginning? What would you do next?
I think the quotation bad thoughts I love, because there's so much to unpack there. Is that for me, I'm not just looking for responses. I'm watching body languages, right? Is your appropriate eye contact is where I need to move to that. Hey, I'm seeing that you seem like you're a bit uncomfortable there, right? What's going on? Is this usually normal for you? And then just explain that, emergency room can be very overwhelming. I'm hearing noises, there's beep happening there. There are people moving, you feel like there's no privacy, and I can see how that can make someone uncomfortable, right? And it looks to me already that you have things already going on, right? So I just want to unpack that a little bit. And then most times I get, oh yeah, you are right. This is a bit too much. My day was just too much. Okay, tell me a little bit more about your day and, the bad thoughts you're having. What does that look like? Right. And you can get like, it just seemed like, I lost my job last month, like you said, or I broke up with my girlfriend and, it's just been very hard. Oh, I can see how that actually could be very uncomfortable and overwhelming for someone. Right. And then how do you cope with this discomfort and all this stuff that has happened the past month? Right. Oh, yeah, it's just I've been drinking, just to get through it. Oh, I can see that, right? And then, drinking, but how much do you drink? And I see that he drank this morning, and that just want to expand that a little bit of drinking and how much, vodka do you drink, right? Well, I drink about a pint. Is a pint usually normal for you, or you drank a little bit more today than yesterday? So you just unpack, and then as you begin to unpack that, then you kind of see what the bad thought look like. Most times you end up, there's really no psych eval needed, right? And then we see, what happened from there. So it's just education and unpacking what's going on and then providing some clarity. That's what I would do.
Okay, sounds like a good start. I love the way both of you, you guys both emphasize building a rapport. And I love that, because if there's any strategies for our navigators, you have to build that rapport, because they're going to tell you what you want to hear. But having these different views and how each approach, like you said, take bits and pieces from Yvonne and David, because you have to make it your own and have that rapport with the patients. I'm going to take it a step further with this case study, just to stir things up. Is he definitely says that he has attempted suicide in the past. Is that going to change anything for you guys, David?
I don't think so, not in terms of the intervention. My focus with this patient would be doing a lot of psychoeducation in tandem with what he has going on. So if he's saying, oh, I stopped taking my psychotropics and my mood got really bad, it's like, well, yeah, that's really understandable. That's kind of the role that our mental health medications play. And when we stop using them, those symptoms can come back, and sometimes even worse. Or, for the substance use side of it, it sounds like you had some alcohol this morning. You can seg right into a clinical assessment of, do you often feel like you have to have a drink in the morning to help with withdrawal symptoms or feeling nauseous? Is that common for you? Have you felt that before? And then so getting more information and feeding back to him what, from our professional sense, since we learn all these things, is getting them on board and why we're concerned and what that looks like. Now, whether he needs to go to a psychiatric institution or not, my follow-up would pretty much be the same, is regardless of where it is that you end up, whether that's home or at another hospital, when you feel up for starting to talk about it or address these issues, this is what that will look like.
Love that. Okay. Yvonne, do you have any other words to add or any other view?
I even though that, past, attempt will not change my intervention, is that I'm comfortable exploring that. The comment is to find out how long ago was this, right? And if you're not a social worker, I want to also recognize the discomfort in that question, right? That not everyone will feel comfortable asking that. And if you don't, then it's okay. If you feel comfortable, I think it is an important question to ask is, and I always start with this, I really appreciate you sharing that with me, because oftentimes it's hard to do so. I really appreciate you sharing that with me, but if you don't mind me asking, how long ago was this, right? Because it's important to know the timeline for me to better understand his stopping medication, right? And how that plays a role and then moving forward. But it is, for me, a question I'm comfortable asking timeline. And then the outcome of that based on how that conversation goes.
You know what? And I really hope that this helps the navigators, because what I feel is you're telling them you have the plan. Your plan's not going to change depending on circumstance. You're always going to have the same plan to go into talk with that patient. And I think that's really important, because when you feel comfortable, nothing can change you. Even if they're yelling, screaming, your plan is always your plan. That's, and feeling that confidence and feeling comfortable, back to Yvonne's words, with your plan and going in the room. So what I'm hearing is, it's basically like, no, even if the patient was just substance use, you're going to do what you need to do. And you know how to do that. So I love this. And like I said, this is probably a patient in your hospital. And again, just have the plan to go in there and explore and talk and find out what you can about the patient and how you can help them. It's really them leading the journey. So I thank you guys. You guys have been wonderful. I wish we could have some more time, and I'm sure you'll love to come back, right? Yeah. Okay. All right. Because we love having you. So that's our case study. I really thank you, Yvonne and David, for giving us some insight, especially with social worker. And like I said, you guys are just, our role models. So we thank you very much for joining us today. I am just going to real quickly address mental health issues. And you guys probably already know this, but, there's been so much focus right now on mental health crisis. In 2020, there was approximately 1 death by suicide every 11 minutes. In 2020, people aged 10 to 14 and 25 to 34 years, suicide was the second leading cause of death. And so again, you know, we know the statistics for overdose deaths. So more than ever, we need help. 988. If you guys have not heard of this number, I preach it. I talk about it whenever we can. 988 is a great number for crisis. And non-crisis as well, but they will connect them with somebody in their own local community. Okay. So it's a national number, but they have local resources. So this is a great resource if people are in crisis. And lots of times I give this to family members because a lot of times, you know, our patients don't want this information, but we really need to put it out there. And I do want to just explain, we always have to have a DEI component, diversity, exclusion, or diversity, equity, and inclusion, because we don't want to exclude anybody. But mental health disparities with mental illness, percent receiving services, overwhelmingly, it's 48% of white people, 31 and 31% for Black and Hispanic, Asian 22%, and then 2 or more 46. So what I take away from this, you guys, and what I want you to take away, it affects everybody. There is nobody that is not immune to mental health. And some suicide facts. You know, 2021, 48,000 Americans died by suicide. And so you can see from here, you know, these are the facts that are going on right now, 132 suicides per day. So again, just really, you know, educate yourself, talk to your patients. The rate of suicide is highest, and this is maybe surprising to some of you, is middle-aged white men. That is the highest rate. And men in general died by suicide 3.9 times more than women. And again, these are some just statistics. What's really alarming, in 2021, firearms accounted for half of all suicides. So again, these are just some facts, and, you know, educate yourself. So that leads us to a wonderful resource. I'm going to let the folks from the Be Well line. I met Sarah Dominguez at an event, a Recovery Happens event, and I was really excited because I found out we're kind of like, in the nonprofit world, we're kind of like sisters, because they work with Department of Healthcare Services in the state of California, and so we. So you know me, I'm always trying to find you guys some statewide resources. And when I talked with Sarah, and we had this idea of her coming on, I was really excited because she's got a lot to offer. So Sarah, I'm going to give it to you and Tiffany.
Awesome. Thank you so much for having us today. Thank you everybody for logging on, and just for the amazing work that you're all doing. So incredible to just listen and see how you're all feeding into each other. But I am Sarah Dominguez. I am the Northern California Outreach Coordinator for Be Well Line. My colleague Tiffany Smith handles the San Diego County area. We are a statewide program, so we have people everywhere. And we're really excited to be able to share a little bit more about what Be Well Line is and what we do. Sherry, should I give like a little wink if I want you to go?
Perfect. Gotcha.
Awesome. So a little bit about us. We are under Alter Health Group, which is our parent organization. We started originally under a FEMA grant. And we used to have this national reach, but after that grant kind of came and went, Alter Health Group saw Be Well Line and was like, okay, people still have a need for this additional mental health support. We want to keep it alive. So then we recently got the CalHope grant, and that took over, and we became California focused. And since the beginning of Be Well Line, as you kind of see some of these numbers in these slides, we've had 100,000 first encounters. So we're really excited about that, and being able to just let people know what's available to them. I am going to actually do that. So what is Be Well Line? I mentioned a little earlier that we are a statewide program. We are sponsored through CalHope. We are free to California residents, and we have a few things that we offer, which includes 24/7 live peer support counseling access via phone call or on our website. And we also have a continuing care aspect and virtual support groups as well. And then this is just kind of simplifies our 3 parts too. So the peer support counseling for our warm line services, the peer support counseling through our continuing care program, then our emotional support groups. Thank you. And then just going piece by piece to different services we offer. So the warm line is a peer support line where anyone can call our chats 24/7. There will always be somebody picking up. So it's very much seeing the person where they are and that need for emotional support. As you can see, there's some examples here about dealing with stress and anxiety, perhaps the loss of a loved one. The peer support counselors are there to be able to take people to come as they are and address that emotional need at that moment to be able to help them through that. And then just to really drive in this point of care seekers being able to be vulnerable because everything is safe and anonymous. Honestly, you could even use an alias if you so wanted. That includes our continuous care program as well. And it could be our warm line can also be utilized for all of our other services. So even if you are in the continuous care program or you do attend a support group regularly, you would still be able to use the warm line if you needed more support, which is completely fine. Sometimes we do. We've all been there. I also wanted to mention that we offer our services in Spanish too. So we support English and Spanish at this time. Unfortunately, we don't have additional language support, but I'm really hoping as the need increases, they will see that and they will add to it. I'm very hopeful because in the past, Be Well Line has adapted to the needs of care seekers, and we've been able to grow that way. And people are usually able to get connected with somebody, and this includes in English and Spanish, within a minute. And so I forgot my cue. So for these services, I just really want to emphasize too that regardless of citizenship status, if a care seeker has access to insurance or none at all, this service is available for free. There's no copays, there's no waiting period. So really any of us who are residing in California could utilize this resource at any given time. We really just want this to be accessible, and the state's funding it, and we just want to be able to let people know what's available to them. And then a little bit more about our continuing care program, that aspect. It's where a care seeker can speak with the same peer support counselor each and every time. So they have that rapport with somebody. And when registering for the continuous care program, they could ask for somebody either with a lived experience or maybe they have a gender preference. Just speaking from a personal level, I recently got my fiance into the continuous care program, and we were able to register him. And he said, I want a male peer support counselor who has a lived experience with anxiety. And I don't mean to expose my fiance's air out his dirty laundry, but I just want to emphasize how much I believe in this program because I gave this to the person that I love the most, who I saw struggling. And he's found it very rewarding to be able to have that continuous check-in with somebody. And also somebody who could not only meet him where he is emotionally, but also guide him through different goals that he has. And that's what the continuous care program does. And this is just a little bit more about the different ways that our continuous care program could be utilized and different things that it does. So some facilities use it as post-discharge support. Peer support counselors will utilize aftercare and discharge plans. There's also tailored care in terms of, again, seeing the care seeker where they are. And then we also have client surveys as well. So being able to measure that progress to see how we're able to help them and how they're able to improve, and where we could support more. And then I almost forgot my cue again. And then this is a little bit more about our peer support counselors, because I know we say peer, and peer can mean so many different things in so many different contexts. So I just want to clarify some of the stuff, what we mean by peer. So the model they use the SAMHSA peer support model. They have trainings and certifications with recovery models, person-centered care, trauma-informed care. They have their peer support certification. They have mental health first aid, and this isn't on there, but they also have their Columbia Suicide Severity Rating Scale training. And that's just because, you know, even though we are a warm line service, people still call in crisis, people still call needing resources. So we make sure our peer support counselors are equipped for that. They utilize a lot of motivational interviewing, and then the delivery, again, just being able to connect care seekers to resources as needed, assist in different goal setting and meeting those goals and creating healthy habits. And then just being able to listen. The power of being able to have your feelings validated, I feel like is so crucial. And that's definitely the type of people that our peer support counselors are. Before we even put somebody behind a phone as a peer support counselor too, we take the recruitment of them very seriously. Thank you. So Tiffany's laughing at me. So we have them do a lifespan background check, and that's just to ensure like basic level safety. But then Alter Health Group also developed our Care Predictor Index. And basically what that is it's a combination of different proven personality tests combined to measure an individual's therapeutic alliance. And you all know how important a therapeutic alliance is with somebody in your jobs, being able to build that rapport, have that empathy, and a little bit of lived experience as well. And the reason that we use this Care Predictor Index is because of the therapeutic alliance results it shows us. So if you don't mind going to the next slide. Oh, I thought there was another slide about that. My bad. There it is. Sorry about that. So as you can see, we have a pretty high therapeutic alliance score, which we're really happy about because we feel like that's a big key component in individuals being able to meet their mental health goals or recover or help them through whatever season they're going through to continue seeing that resource. Okay, now next slide. Thank you. So when it comes to registering for a continuous care program, we have a phone number, and then we also have a form. The online form, I will be able to send a link to people. After this, I will be able to post my contact information, and Tiffany Smith will post hers, and either one of us can get you access to this form. But this is the process of what it looks like: calling the number, being able to share information with the peer support counselor, and then usually, honestly, when I've done this form, there's usually a appointment available within 24 hours. I think the longest I've seen is like 48 hours. So we're able to see people and get them connected with peer support counselor pretty quickly. Thank you. And then this is just like a little graph of like where we've been able to get different people calling in, part of our continuous care program. And we're really excited just to be able to let people know what's available to them. And then this is just different data that we've gotten from our client surveys about what people may call in regarding, and then that they feel better after talking to somebody. So as you can see, a lot of different people call us for a lot of different reasons. We see a lot of substance use, anxiety, depression, and a lot of finances too, suicidal ideation. But we're really just there to be able to, again, provide a non-judgmental ear and be able to validate and also help create some action plans as well. And there's some of our information. And like I said, I'll be posting my contact information shortly. Please feel free to reach out to me if you have any more questions. And Tiffany, is there anything that you feel like I should have added or?
I think you did an amazing job, Sarah. Yeah, there's a lot of information. You touched on the virtual groups as well on the website. And yeah, all of that's available on our www.bewellline.com. You can sign up, and I believe they're 45-minute sessions, correct?
Yes.
Yeah. Yeah, I think you covered it. And the continuing care line, the care seeker has the ability to speak with the same counselor. They're 30-minute sessions for an indefinite period of time. And I think that's pretty much it. English, Spanish, California wide. Oh, and they don't even need to be documented. So
Yeah.
as long as they're considered California residents, there's no barriers. You don't need Medi-Cal. And yeah, that's about it.
Yeah.
I do have a question, because one thing that really struck up is about the age limit. Do you have an age limit for people calling and getting help?
So as of right now, we just to work within consent laws, our warm line is technically 12 and older, and our continuous care program is technically 18 and older. However, I have had because I talk to some schools sometimes, and I have had parents ask me, oh, well, my child is, 11 and a half, or they're 10, and they really need somebody to talk to. Can I be in the room with them? And the thing is that our peer support counselor is never going to be like, oh, sorry, you're calling out of state, or oh, sorry, you're 10, and they're not going to do that. They'll still be able to provide that emotional support in that moment. The only limit would come to if a 10-year-old was like, man, I really wish I could see a therapist. Our peer support counselors may not be able to guide them towards that grant. In kind of like how if somebody out of state was calling and they were like, man, I wish I could see a therapist, they would really only have those California resources for them. So that would be like where the limit was kind of drawn. But other than that, completely accessible.
Yeah, and I love that you have something for adolescents, because sometimes that's really hard to find resources. And the other great thing you touched upon was grief counseling. I don't know how many times I have patients with substance use that, really use heavily during anniversaries, birthdays. And so you do offer a grief support group, correct?
Yes.
And they can go anytime, doesn't matter. And it's offered, you said you're once a week, right? For your groups?
Yes.
Okay. So just wanted to throw that out there, because I know we've had a lot of questions about grief support. I know I get that at my hospital, but this is one resource that you have for adolescents and grief counseling. So I thank everybody today. This has been great. I hope you've learned. I hope you take away with some final thoughts here, right? Utilize your hospital and community resources, collaborate, connect. I'm using all these words that our social workers have said today. Definitely review your role. We talked about your role and what your scope of practice is, and review our resources on our website. We've given you that toolkit, and there's some there, as well as use our new friends here, Sarah and Tiffany. So I thank all of you for joining us. We can pause real quick for a few questions. I don't know, I can't see this. Is there any questions in the chat? Do we have access to the slides? Yes, there will be a post-event email. Anything else, you guys? Okay. They did say they do not have to have insurance. Absolutely. There's no insurance. So, and I think, if you didn't catch what Sarah said, it's worth repeating, is it could be anonymous. You could put John Doe on the warm handoff sheet, right? They do, if you go online, there's like a warm handoff that you kind of fill it in for them. And if they don't want anybody to know, and again, that stigma, we talked about that today, right? You guys, our social workers, it's that stigma. So what a great resource to say you can be anonymous and get help. So I really hope you choose, use this resource, as well as our tips and strategies for our social workers. I don't see any more questions. So anything else? All right, you guys have a great day. I'm going to give you time. If you have not been on our Bridge Academy, please go onto our website. All of our courses, our Sun Training 101, our Navigator Focus series are added onto there, and you can watch all of our presentations again. So we're really happy to have you to contact us, mentors@cabridge.org. As you know, we always have our mentors available to help you out and answer any questions. So feel free to help. Always reach out or see you on Slack. We'd love to see you on Slack, you guys. And of course, you know me, I'm Sherry Cisneros, leading the team for the Navigator program, and we are honored to have you there. Have a great rest of the day. Thank you for coming. Bye-bye, guys.
Thank you so much for having us, and thank you for all the work that you do.
Thank you.